ATE assessment given by Megan. Just a couple of rules before we begin. If you're watching on the Zoom, any questions, you can pop them into the chat or the Q&A and Megan will address them at the end. If you're watching on the Facebook Live, just make sure to comment your questions and we'll make sure that they're passed on. That's all from me. I'll hand over to Megan to begin. Thank you.
Hello, so I'm Megan and I'm a 5th year student at Aberdeen, and today I thought I'd talk a bit about ATE assessment. So this is something that's not very often taught about in medical school, at least it wasn't at mine until this year, but it's really useful for when you're in FY1 because it's something you have to use quite a lot. So we'll get going. If you have any questions, as we said before, just pop them in the Q&A and I'll do all the questions at the end. And I've got some scenarios to finish off with because it's quite hard to, this is obviously a practical topic, which we can't do over Zoom. So I've tried to do some scenarios and hopefully that will work, but we'll see. So this is a disclaimer, which you can read at your leisure at a later date. So the learning objectives for today: understand the situations when an ATE assessment may be required, understand the components of an ATE, and think about how you might write it down, how you might document what you've done. So what is an ATE to start off with? So it's similar to a primary survey. So some of you might have heard this term primary survey. It's used quite a lot in emergency medicine or in pre-hospital scenarios, and they are very similar. There's some slight differences, but for essentially they are the same thing, except an ATE would be more in a hospital setting, but the terms are often used interchangeably. So it's a system that you can use to assess a patient in order of problem severity. So by following this system, you essentially find out what is going to kill your patient the fastest, and you address that first. So that comes at the top of the list. So the problems are addressed in order of which is most threatening to life, as opposed to by system. So if you were to go and examine a patient just on a day-to-day basis with no acute problem, you might examine their respiratory system, their cardiovascular, you might go by system, whereas this addresses it in order of severity. And finally, it gives you a good overview of their clinical condition. So is this person really ill, or are they just a little bit ill? How urgently do you need to act, and who do you need to call about this? So when should you use an ATE? So any deteriorating patient. So if you get called as an FY1 by a nurse to see a patient on a ward because they've got a high news score, someone's news is trending up or their blood pressure is trending down. So anybody who's deteriorating, you should use an ATE assessment as your first port of call of what you're going to do. Anybody who's critically unwell, so any patients who you're concerned about or any of the staff are concerned about, even if they've been critically unwell for a while and you might know what's wrong with them, you still would do an ATE assessment to assess their problems in order of severity. Or if you simply don't know what's going on, if you're presented with a patient and you have absolutely no idea what's wrong with them, well, an ATE assessment is a good place to start because you'll pick up anything that's really serious that you need to deal with right now, and then it gives you time to deal with any other problems later on down the line. Or when you don't know what to do next. So you've tried everything you can think of for a patient, but they're just simply not getting better. Sometimes an ATE is a good way to kind of gather your thoughts and help you decide what should I do next? Or if you've got a whole list of things to do next, which of these should I do first? So now this is the main context of it. So how do you do an ATE? So I'll just run through it step by step. And it seems quite obvious. But it's quite an easy way to remember it. So start with A. So A is your airway. So how do you assess someone's airway? Well, this is probably the easiest thing to assess. You walk into a room and you just speak to them. And if they speak to you back with no issues, then their airway is patent. And you can be quite sure that their airway at this moment in time is fine. You don't even, it doesn't matter what you ask them. If they speak back, it doesn't really matter what they say back to you either, because at this point you're only interested in their airway. So you might be walk into a room and say, oh, hello, Mr. So-and-so, how are you feeling today? And even if they reply and tell you, oh, I'm feeling awful, you know that their airway is patent. So if someone's airway isn't patent, what are you going to do? Well, and what might this look like? So you've probably all heard about stridor. So this is this noisy breathing, it kind of is, and it's quite distinctive once you've heard it. And you can get an inspiratory or an expiratory stridor. So it's quite important to know whether this noises you're hearing on the inspiration or expiration, because they'll have different causes. I'm not going to go into too much detail about airways because that's a very anesthetics ENT focus, but just to cover things broadly, why might someone's airway be compromised? Well, from swelling. So if they've got anaphylaxis, if they're having an allergic reaction to something, this swelling can block their airway. So they might have other signs that would indicate that. But this is especially pertinent if, for example, someone's just had a blood transfusion and then suddenly they can't breathe. Well, they might be having an allergic reaction or an incompatibility to the blood, or they might have just been given some antibiotics and then they've developed this swelling. So allergy is quite an important one. And obviously, if you think someone's in anaphylaxis, you give them IM adrenaline, and that's the treatment. And that's the thing about A to E, is you intervene as you go. So once you discover a problem, you deal with that problem there and then, because these problems are in order of severity. So this is helping you order your treatments. So if someone's got an airway problem, you deal with the airway problem before you move on to other things. So I've put Lego bricks here, very common foreign body in children. So a foreign body obstructing an airway, you might not be able to see it, you might be able to see it. They might not be able to tell you that they've got a foreign body. For example, if they have got a foreign body in their airway, they probably can't speak properly. And an important thing to say about foreign bodies is if it's quite far back, don't try and remove it, because if you push it further down, you might make it worse. This is when you need to call for help. And it doesn't have to just be children. So some people with swallowing difficulties, if they've got an esophageal tumor, if they've got a neuromuscular condition, it might be a food bolus that's stuck, that's blocking their airway, or if it's gone down the wrong way. And finally, are they unconscious? So if you have a really low GCS, it reduces the tone around the back of your mouth, and all the soft tissues, including your tongue, can block the airway. Now, this is something that's really easily to resolve. So all of you probably know about a head tilt chin lift or a jaw thrust. And if you try this and it resolves the airway problem, well, then you have to maintain it, but also you know that that's probably the cause of your airway problem, is the reduced GCS. So a little about what you can do if someone's got a compromised airway. Well, the first thing you should be doing is calling for help, because that's what they need. They need specialist help. But simple things you can try. So these on the screen here are Goodell airways or oropharyngeal airways. So they're quite easy to insert. Put them in upside down, twist them round. If someone tolerates a Goodell airway, that's a bad sign. That means they've got a really low GCS, because these are quite irritating. So if someone's slightly conscious, they won't tolerate having that put in. But they might still be unconscious enough to compromise their airway. So this is where a nasopharyngeal would come in. So these are tolerated really well, and you can put them in with safety pins on the end just to stop them going in too far. So they're a really good option. It's maybe if someone's drifting in and out of consciousness, to stop them continually pulling a Goodell out. And then if you're confident with airway management, you might put, so this is an eye gel, or it can be called an LMA. But as an FY1, if you're not confident, just stick with the other two. Doing something is better than doing nothing in an airway situation. Or if you feel like you've got strong hands, you can just stand and hold that jaw thrust until someone arrives. But airway is number one, because that's what's going to kill them fastest. So breathing is next. So the important thing to note about breathing is it's not a respiratory exam. So assessing breathing is different from assessing the respiratory system. So the first thing you're going to do is look at the patient. So there's a patient here, first thing you can see is they're on oxygen. So that's obviously a really important thing to note. But also look at their chest. Are they breathing shallowly? Are they breathing deeply? Are they breathing equally? And how fast is their respiratory rate? So the news charts, they have a really good set of observation, and each of those sections are pertinent to the different sections of an A to E. So for breathing, what are their SATs? What are their respiratory rate? And how much oxygen are they on? And how are they taking their oxygen as well? Because if someone's sat with a nasal cannula in, that's probably a better indication than if they're needing like high flow nasal oxygen or like positive pressure ventilation. So how they're taking their oxygen is quite important. And also in some people, what pattern are they breathing in? So there's certain patterns of breathing which will give you a clue straight away to what's wrong with them. So you might have heard about Kussmaul breathing. So this is this kind of deep, fast breathing that you see in DKA. And you kind of get a seesaw movement of the chest and the abdomen. It's often in children with DKA. Or you might get Cheyne-Stokes breathing, which is a pattern of breathing that occurs at the end of life. So it's the pattern of fast breaths and then no breaths and then fast breaths. And it's quite distinctive as well of an end of life phase. So once you've watched their breathing, you're going to listen. So have a really good listen to their chest. Some patients might not be able to sit forwards, but if they can, it's a lot easier to just examine all the way down the back of their chest. And I know in a normal respiratory exam, you'd probably percuss as well. So in some patients, yes, percussing can be helpful if you think they've got a pneumothorax, if you think they've got pleural effusion, but it wouldn't be your main priority because especially if you don't think they've got a problem with breathing, you want to get through your assessment as you can. But if you see someone's got a problem with breathing, you need to intervene. So you need to give them the oxygen or increase their oxygen as you go. And then based on what you find when you listen to their chest, you might want to think about what investigations you're going to order. So if you hear something on their chest, or even if you don't hear anything, but you've got a suspicion, you might want to order a chest x-ray. So this is another thing about an A to E. You intervene as you go along, but you also think about the investigations you want as you go along. So yeah, the important thing to remember is it's not a respiratory exam, it's a breathing assessment. So whilst assessing things like finger clubbing and all the signs you would normally look for in a respiratory exam are really, really important for that situation. In an emergency or an acute situation, probably not as important. Still important, but probably not your priority. So next is circulation. So in circulation, the first thing you're going to look at is from their OBS chart is their heart rate and their blood pressure. So you want to feel their radial pulse. So a radial pulse can give you quite a lot of information. If you can't feel their radial pulse, the likelihood is they have a blood pressure of below 90/60, because that's kind of the average pressure that's needed to sustain a radial pulse. So that's why this is quite an important sign pre-hospitally, where you might not have access to a blood pressure machine. If you can feel their radial pulse, you can be fairly confident their blood pressure is above this. Also, you can assess the kind of character of the pulse. Is it weak? Is it thready? Or is it quite a good going pulse? So that's really important. And if you can't feel a pulse peripherally, you move centrally up until you can find one. So heart sounds, listen to the chest, and listen in all the locations you would normally listen to in a cardio exam. And this is obviously really important because it can give you loads of information. It could be a new endocarditis that no one's picked up before, or it could be that they're in AF, which you would hopefully realize from their pulse, but listening to their heart can also give you indications, or they might have a new murmur of another sort. So that's really good. But often you listen to the heart and you don't really know what you're listening to, but it might push you to order an ECG or order in other investigations. and then finally blood pressure. And you need to decide if something's wrong with their blood pressure, what are you going to do about it? So if they have really low blood pressure, you might consider a fluid challenge. So that's a really important thing to consider, because you want to intervene as you go. So next is disability. So D and E, which are disability and exposure. Some people put the things that I've put in D and E, and some people put things that are in E and D. Doesn't really matter as long as you get them all in. So personally, I find it easier to remember that in D for disability is all the other systems exams that you would do normally, or ones that you think are relevant here. So abdominal exam, always feel someone's stomach. Even if they've come in with a respiratory infection or they've come in with a broken leg, but they're suddenly unwell, make sure you feel their abdomen. Is it soft? Is it tender? If it's an elderly person and they've suddenly gone like off legs, are they constipated? So this is a good time to ask about, or ask the patient or ask the nursing staff, have they opened their bowels? Have they passed urine? If they're tender suprapubically, it could be a UTI. So this is a really important system. Often it will just be soft, non-tender, nothing to find, but it's really important not to miss this out. And another one is GCS. So this can tell you a lot about their neurological function. So if someone's got a GCS of 15, that's fine. If their GCS is lower than that, you need to think about why. Why is that GCS low? Because that is an indication that something somewhere is not going according to plan. But it's also important to remember, well, what's this patient's normal GCS? So in a patient with dementia, they might always have a slightly reduced GCS because one of the criteria for assessing GCS is verbal score. Are they confused? Well, to you, a patient with dementia might always seem a little bit confused, so they might always have a slightly low GCS. So you need to remember to interpret it in the context of your patient. And it's also, for example, if someone's had a head injury, GCS is an important criterion in whether they're eligible for a CT head or not. Then this is picture supposed to represent wounds. So make sure you check if this person's got any wounds anywhere. Have they got any pressure sores? Have they had surgery and they've got a surgical site? You always need to look at the surgical site. Even if they're complaining of pain somewhere completely not near it, if they've recently had surgery, you need to look for that. And you need to look at the dressings, and you need to see if there's anything seeping through. Is there anything, if they've got a pressure dressing or a vac dressing, what's come out of it? And when was it, how long ago was the wound? Or is it just a chronic wound that's not healing? Because obviously an important thing not to miss is sepsis, and this can quite easily come from minor skin wounds. And then finally, this is just to represent the bones or long bones or anything else that you might need to examine that's relevant to the patient. So for example, if someone's got stomach pain following surgery, probably not going to examine all the joints in their legs. But if it's an elderly person who's just had a fall on the ward, well, that's really important because you don't want to miss a hip fracture, even if they're in with a chest infection, but they've just slipped going to the toilet and the nurse has asked you to come and assess them. You need to check their hips or check their bones, because they might not immediately complain of pain there, but you don't want to miss that. But then might not always be relevant. And finally, E for exposure. So exposure on a news chart, this is your temperature. Is the patient too warm? Is the patient too cold? Or are they normal? And you also have to look at the patient. Do they look cold? Are they covered in blankets trying to keep themselves warm? Or are they so hot they've taken their shirt off, they've taken all the layers off, and they're physically sweating? This can give you a lot of information about their clinical condition. If you've got a patient whose temperature is always low, or maybe you need to think about their nutritional state. Are they underweight? Is that why they're cold? Or if they're not, are they hypothyroid? Is that why they're cold? Now, these aren't necessarily acute things, but they're important things. And this is why they're in E. So they're important things not to miss, but they're not going to kill your patient as fast as an airway problem. And then something else to remember in exposure is have you looked everywhere on your patient? And this sounds like an unusual thing to say, but if someone's short of breath, have you checked their calves for a sign of a DVT? For patients covered in blankets, always just have a quick check under the blankets that you're not missing anything blaringly obvious. Have you exposed all the sites that you need to look at? Have you looked at the wound sites if they've had surgery? If you think they might have a pressure sore, have you checked the pressure sore sites? If they're diabetic and they've suddenly got a sepsis and you don't know where they're coming from, have you checked their feet? Because diabetics might not often report a foot injury, but it can quite easily get infected. So whilst exposure is temperature, so are they spiking fevers? Are they too cold? It's also exposure in the sense of, have you checked everywhere on your patient? You're not missing anything. You've not exposed the site to order examine them properly. So that's an A to E. It's quite a quick run through, but you'll probably all have heard it before. So now we're going to think about documentation. So when you're called to see a patient because they're unwell, you need to document what you've done, because the next person to see the patient might not have spoken to you, you might not have spoken to them, they might not have met the patient before, you might not have met the patient before. So sometimes this documentation in the notes is the only communication between the staff about the patient. So how you go about documenting this is really important. So I was thinking about how do I show this? So I'm hoping you can all read this on the screen. So this is just an example I've done about how you might go about documenting an A to B assessment you've done of someone. So it's not perfect. Everyone will have a different way of documenting. This is just kind of give you an idea of how you might lay it out. Because as I've put here, it's not in the notes, it never happened. So if you've gone to a patient and listened to their chest, but you haven't written that you've listened to their chest, well then how's anyone going to know that you actually did hear crackles in the upper lobe and you think they've got a pneumonia? Like, it's important. But also at the same time, if they've got a clear chest, you need to write that, because otherwise people might be wasting time in the morning thinking they've got chest signs when actually they haven't. So I'll just have a quick talk through this one, but everyone has their different ways of documenting. First thing to point out is make sure you've got a sticker on the top of the notes, and all different hospitals will have different ways of documenting this. And I also realized that this scenario is written on an orthopedic paper, and this gentleman is probably not an orthopedic patient, but that just kind of highlights the thing. Make sure you're writing on the right paper from the specialty you've come from, because sometimes people will flick through the notes looking for specific notes. But always put the date and the time and the reason why you're there. So is it a ward round, and then who's doing the ward round? Or are you coming to review their medication? Or so here, ATSP, ask to see patient. So that's when the nurse has called you to ask you to come and see the patient. And put why they've called you. What was their concern? So for example, in this patient, which is a completely made up one, so the details are irrelevant, but ask to see patient because they've got a news of 8, and then the news obs here. And then you move on to documenting your assessment. So I'd like to put it in order of A, B, C, D, E, because that's the order you assess them in, so that's the order you can write it down in. But often you would assess the patient, intervene and manage, and then write it up afterwards. Don't waste time writing things down when the patient needs oxygen. So A, airway patent, sat up talking in bed. B, the obs that go with B. And then the assessment, you've listened to the chest. C, the circulation assessment. And this is an important point here, was informed by the patient that he's normally hypertensive. So if someone's got a normal blood pressure, but they're normally really hypertensive, then actually that might be low for them. The heart sounds and the negative findings, so there's no edema. So that's just as important as positive findings. D, always, so I'm not the best drawer, and it doesn't have to be in a work of art, but always try and draw what you've seen or what you've examined, because that's really helpful for the next person who examines them to know what's changed. And then here, look at the dressing and look what it looks like and why they've got the dressing. And then if the nursing staff are there, when did they change it? Because if they've just had a new dressing put on, it might look fresh and clean to you, but actually the last dressing could have been soaked through. And then exposure, temperature, and the trend in these observations is really important. Then finish off with your impression. What do you think's going on? This doesn't have to be a diagnosis. So at this point, you might not even know what's wrong with them, but what's your impression of the patient? So here in this patient, I've written abdominal sepsis. I don't know why they've got the sepsis. I don't know whereabouts in their abdomen. It might be, from the sounds of it, it could be a paracolic collection, but you don't really know that. So it's more of an impression to give the next person who reads it an idea of what you were thinking at the time. And then a plan. Always finish with the plan. So you might have already done some of these things. So for example, if the patient needs oxygen, you're going to give them oxygen at B, but you also need to write that in your plan at the bottom. And then this patient is already on oxygen, so that's why it's not in the plan. And then you need to finish it off with your name, your designation, so FY1, FY2, signature, and your bleep number. So if someone wants to ask you about it, they can find you. So hopefully that's a quick overview of how you might go on about documenting what you've done. So now we're going to do some scenarios. So I'm not entirely sure how well this is going to work over Zoom, but we'll give it a go. So what it is I've got two scenarios, and there'll be multiple choice questions, and you can answer in the poll and then move on. So the questions are about what you would do next in these scenarios. So we'll give it a go. And if you want to know any more information to make your decision, pop it in the chat and I'll give you the information. So the first one is scenario 1. So you are the FY1 on for surgery overnight, and you're asked by a nurse to come and review a patient on ward 3A. This is not your normal ward and you don't know the patient. So that's quite usual for if you're the FY1 on for nights. You might be on for several wards with patients you don't know. So you arrive on the ward. What's the first thing you should do? So A, get a handover from the nursing staff. B, find the patient's notes. C, introduce yourself to the patient. D, check the most recent bloods. E, feel for a pulse. So I will start the poll. And I won't, just quick decision. And then I'll just give you a few seconds. So I'll give 20 seconds for each question because there's just an idea of what you'd put. Okay, so that's good. So 43% of you have put get a handover from the nursing staff. And I'd agree with that. So get a handover from the nursing staff. So all of these things are good things to do, but the very first thing you want to know is why you've been called to see this patient. So often they just bleep you and you'd ring them and they say, can you come and see this person? And that's all the information you've got. So when you turn up on the ward, you want to know why you're there or why they want you to be there. And all of these things are important, but not the very first thing you should do. So the nurse on the ward gives you this S bar. So S bar is a format of giving a handover. So S, situation. This is Alexander Watson, who is a 65-year-old gentleman with an increasing oxygen requirement over the last 2 hours. So background, he had a right total hip replacement 4 days ago, normally fit and well with no known respiratory pathology. Assessment, he has a new score of 6, scoring for 4 litres of oxygen, 88% of SATs and a heart rate of 119. Recommendation, please could you come and assess him? Okay, so take that information in because you'll need it for the next to the questions. So you go to see Mr. Watson, and this is a picture of Mr. Watson on the right here. So what are you going to do now? Check the most recent news, ask him how he's feeling, bleep your registrar, listen to his chest, or get IV access. So I will, similarly as last time, give you 20 seconds to put what you think you would do. So 10 more seconds. Yeah, okay. So that's good. So 77% of you have said ask him how he's feeling. So that's really good. So I'd agree with that. So that's your A assessment. Ask him how he's feeling. If he replies, you know his airway is patent. So all of these things, again, are things you might do, but this is what you should do now. What's the first thing you should do? And asking how he's feeling is a good way to assess his airway. So same patient, Mr. Watson tells you he suddenly began feeling breathless 2 hours ago, but other than that, he's feeling fine. You begin to assess his breathing. So he's on 4 litres of oxygen, but his SATs are remaining at 88%. What are you going to do next? Turn up his oxygen, auscultate his chest, get IV access, change the oxygen delivery device, or insert an airway adjunct. So, Paul, for 20 seconds, what are you going to do now? So 5 seconds more. Okay. So pretty even split on this one, but I would agree that change his oxygen delivery device should be what you do next. So whilst he's on 4 litres, and you can see in this picture here, so this is why looking at your patient is really important. The numbers are one thing, but you have to look at the patient as well. You can't just go off the numbers. So this patient is on nasal cannulae, and he's on 4 litres, but his SATs are 88. And we know Mr. Watson doesn't have respiratory pathology, so he's unlikely to be a CO2 retainer. So we should be aiming for SATs of about 94 ideally. So he needs more oxygen. But you can't turn up his oxygen because the maximum rates you can give through a nasal cannula is 4 litres. So before you can turn it up, you need to change the delivery device. And then once you've done that, yes, the next thing you're going to do is auscultate his chest, by all means. But you're going to do the oxygen first because you intervene as you find. And no matter what you find when you listen to his chest, you're still going to be giving him more oxygen if he's got SATs of 88. So yes, it's important, but this dealing with the problem you've just found is more important. As for the airway adjunct, we know his airway's fine. IV access, well, that's a circulation problem. We'll come to that. And we've talked about the others. So you finish your assessment. The rest of C, D, and E, they're unremarkable. The only thing you find is a tachycardia, which we already know from his news. So at this point, in your impression, what's your top differential? So this is a bit more of a theory question now. So pneumonia, COPD, sepsis, MI, or PE. So quick poll. And the important thing is, it doesn't matter if you get the differential right, as long as your A2E is accurate, then your senior might come and read your A2E and come to a different conclusion. but just giving an impression of what you are thinking at the time is important. Okay, so we'll end that there. And yeah, well done. So I would agree that the most likely thing in this scenario is a PE. So all of these are possible, but the most likely is a PE. So now you've come to that conclusion, what you're going to do. So this is just a little bit of a side note about PE. So this is the treatment for PE will be different depending on where you are in the country. But the first thing to do if you suspect a PE is do a Wells score. So a Wells score is up here. There's a condensed version of it. You add up the points, and this gives you the probability of a PE. If it's less than 4, it's unlikely they've got a PE, so you would do a D-dimer. So as you all probably know, a D-dimer is an incredibly non-specific test. So D-dimer can be raised in all sorts of conditions. And most of the patients who are in hospital will probably have a raised D-dimer. If you're pregnant, you have a raised D-dimer. If you've had surgery, you've got a raised D-dimer. If you've got inflammation going on anywhere, you'll have a raised D-dimer. But a negative D-dimer is incredibly specific for ruling out a PE. So if someone has a negative D-dimer, it rules out a PE. So you need to consider something else. If they've got a positive D-dimer, you give treatment and then you image. So this goes back to the intervene as you go. If they've got, going back to the Wells score now, if you come down this side because they've got a PE of greater than 4, you give them treatment. It doesn't matter, you don't do a D-dimer because it's not going to change your management. Whatever the result is not going to change your management if they've got a Wells score of above 4. So you give treatment and then image. What imaging you're going to do? VQ scan or CTPA. So CTPA is first line for most people. If you're over 40 or there's got no contraindications, CTPA is what you want. VQ scan is the slightly older version. This has less radiation and it's a nuclear medicine scan. So this is something you might consider for someone who's pregnant or a younger person where you don't want to expose them to the radiation of a CTPA. But anyway, back to A2E assessment. So we'll do scenario 2 now. If I'm going too fast, just say. So you're the FY1 on for over the weekend for an acute medical receiving unit. And the nurse asks you to come and prescribe some more fluids for a patient with low blood pressure. So a really common request as an FY, please can this patient have more fluids? So this is the SBAR from the nurse because you should never just prescribe fluids. You should always find out about the patient and assess them whether they need the fluids. So S, this is Margaret Smith, who is an 86-year-old lady who's got a BP of 95/68. Background, as with most elderly patients in hospital, she has quite a complex medical background. So she's usually a care home resident due to advanced dementia, admitted yesterday with, so PUO is pyrexia of unknown origin. She's currently apyrexial, but spiked her temperature earlier today. She's usually non-verbal, so this is probably because of her advanced dementia, with a history of hypertension, osteoarthritis, COPD, and diverticular disease. She has a DNA CPR in place and a TEP for ward level care. So this is really important to know about a patient, and it's normally on the very front of their notes. A TEP, for anyone who doesn't know, is a treatment escalation plan. So it might be called something different in different hospitals, but this is where, what's the ceiling of treatment for these patients? Are they suitable for ITU? Are they suitable for HDU? Or is it ward level, making them comfortable? And then A, assessment, news of 3 for a BP of 95/68 and a heart rate of 94. So recommendation, please could you come and prescribe her some more fluids? So you go and see her, and this picture here is Mrs. Smith. She's laying in bed, mumbling to herself. She looks pale, but she doesn't look distressed. So you listen to her chest, you hear a mild wheeze with SATs of 94%. What are you going to do next? Give her oxygen, call the respiratory reg, check her airway, move on to assess circulation, or prescribe some more fluids. So we'll just do a quick poll for Mrs. Smith. And I'll just give you 20 seconds to think about what you would do next in this situation. This is a little bit more of a tricky one. It's a bit more subtle. Okay, we'll stop it there. So in this scenario, I would agree, move on to assess circulation. So I'll explain why now. And this one, it's more about noticing the subtleties of a scenario. So move on to assess circulation because, well, whilst you've not spoken to her, she's mumbling to herself. So she's speaking. So you know her airway is fine. And you've listened to her chest and you've heard this wheeze and she's got SATs of 94. If you remember, she's got a history of COPD. So SATs of 94 are probably quite good for her because that you aim for 88 to 92 in people who are known COPD. So I wouldn't give her oxygen at this point, but I'm not concerned enough to call the respiratory reg at this point because she's got a mild wheeze, but we know she's got COPD. But we're not going to prescribe her fluids straight away, so I would move on to assess her circulation. So you go to assess her circulation, but her blood pressure has continued to drop further to 88 over 59. Her heart sounds are normal, but her radial pulse is very weak and rapid. So what are you going to do? Prescribe a fluid challenge, prescribe 1 unit of blood, initiate sepsis 6, carry on with your assessment, or move her to HDU. So we'll do a poll again. And I'll just give you 20 seconds. And it's just important to note, I know earlier I said a radial pulse is normally present at 90 over 60, but that is just an estimate. So it is quite feasible that she'd still have a radial pulse at 88 over 59, but that might be why it's weak. So a couple more seconds. So yeah, so I mentioned this earlier and all of you have got it right, which is good. So prescribe a fluid challenge. That's exactly what you should do in this scenario because you've discovered that her blood pressure is low. So you intervene as you go and you're going to do something about that. If someone's hypotensive, a fluid challenge is exactly what you need to do. All of these things you might consider, but at this point in time, you wouldn't just go straight away give her blood if she's hypotensive because she might not need it. Initiate sepsis 6 if you think she's septic, but not everyone who's hypertensive is septic. Carry on with your assessment. Well, this is a significant finding. You need to do something about this and you need to do it now. Move her to HDU. Well, potentially, except this lady had a TEP or treatment escalation plan for ward level care. So it's not appropriate to move her to HDU. Bit of a side note on fluid challenge since it's come up. If you've got signs of hypovolemia, so hypotension, tachycardia, or they look dry, you want to give them a fluid challenge, unless there's contraindications. So this is things like severe renal impairment or severe heart failure, in which case you need to be getting senior help because this is not a decision you're going to be making. But there's not many contraindications for fluid challenge. So give 250 to 500 mils of Hartmann's, or I think it's called Plasmolite in some places. So it's called different things. But whatever your resuscitation fluid in your area is, and you give it over 5 to 15 minutes. So essentially as fast as you can. The debate whether to give 250 or 500 is a little old lady. Give them 250 and give it slowly. If it's a young fit guy, give them 500 and give it as fast as you can. It's all about their physiological reserve. How much and how fast can they cope with it? If you get an adequate response, so their BP comes up, their heart rate slows down, then you just give them maintenance fluids and you've solved the hypovolemia. If they don't respond, repeat it and do it again. And you can do this up to 2,000 milliliters. Although as you get higher and they're still not responding, you need to be getting help because this is a serious problem. So I wouldn't wait until you hit 2 liters before you call, but you call earlier and then continue to give them a challenge whilst you're waiting for the help to arrive. But back to the scenario. So back to Mrs. Smith. After several fluid challenges, her BP doesn't respond. So you get the nurse to bleep your registrar. You carry on with your A to E whilst you're waiting for her to arrive because you've reached the maximum of your fluid challenge. Which part of D will be difficult to assess accurately in this particular lady? Abdomen, blood glucose, long bones, urine output, or GCS? So I think we spoke about this earlier, but I will launch a poll and just give you 20 seconds. So a couple more seconds. Yeah. So I would agree in this lady, GCS is going to be difficult to assess. I mean, given her history, a lot of these things are going to be difficult to assess, but mainly GCS because we know she's got advanced dementia. So how do we know that her verbal response is not her normal verbal response? And if you think about how you assess motor, you assess it by asking her to do things, or you assess her response to pain, and that's going to be difficult to assess in her. Although I do agree with some of you said it will be difficult to assess urine output. Well, yes, it might be, but not as difficult or as pertinent as the difficulties in assessing GCS are going to be. So a little bit about GCS. That's just the reminder of the scores. So motor response obeys commands. Well, if she's got dementia and doesn't understand what's going on, she might not obey commands, but that might not necessarily mean her motor response is decreased. And her verbal response, well, if she's confused all of the time, it's going to be lower, but how do you know that that's not her normal? So someone with advanced dementia or other cognitive impairment might always have a lower than normal GCS. So you need to find out what their normal is. But back to Mrs. Smith. So you conclude your examination with her temperature, which is still normal. And once the reg arrives, you finally get a chance to read her notes. So her hemoglobin from this morning was 88. And you now suspect she's bleeding. Looking at this picture, so the picture on the left, what should you have done in your examination that might have highlighted this possibility earlier? So think about what we've spoken about in the assessment, and just, this one isn't a poll, so just comment in the chat if you've got any ideas. No worries, but not, I realize it's a little bit of a cryptic question. But what, from the picture, what might you do that might highlight where this problem might have come from? It's a little bit of a tricky one. So I'll just wait a couple of seconds, but then I'll talk about it. Okay, no ideas, never mind. So this lady here is lying in bed. She's bundled up in blankets. Or did we look under the blankets? So if you lift up the blankets and you see a puddle of blood, well, she might be having a rectal bleed, and we know she's got a history of diverticular disease, so it's not out of question that she might have this. She's also elderly, and we know, while she didn't have time to go and look in the notes when you were doing your A to E, exposure E is really important. If you don't do E properly, you'd never know that she was having a rectal bleed, because if she's incontinent normally, she might be wearing a pad. This might absorb all the blood, so it wouldn't be blood leaking onto the floor, in which case you'd obviously notice it earlier. So this is why this situation highlights the importance of exposure. Make sure you've checked every possibility, because you don't want to miss something like that. You don't want your registrar wife lift up the sheets and there be blood everywhere that you haven't noticed. So yeah, this shows the importance of exposure. So I think that's me almost done. So take away messages for today. If in doubt, do an A to E. It will help you figure out what to do. Always document what you've done. And the last other point, so from the scenarios, 4 litres is the maximum you should give through a nasal cannula. That's really important to remember, because a lot of patients on wards will just sit with the nasal cannulas on, and you'll want to turn their oxygen up. Fluid challenge. If they're hypertensive, give them a fluid challenge. And 5, always check under the sheets. You don't want to miss a swollen leg or an infected wound, or in the scenario we talked about, a rectal bleed. So I think, oh, let me go back. That's me done. So thank you very much for listening, and I'd really be grateful if you could fill out the feedback, because it helps us plan for other sessions. So for example, the last one I did, people said the sound quality wasn't great. So this time I've been able to use a headset. So it is really important that you fill out the feedback, and I'd be really grateful if you could. So thank you very much, and I hope that was useful. And if you've got any questions, I will answer them now, or pop them in the chat, pop them in the Q&A.